All right, good evening, everyone. I wanted to welcome you all to this year's fourth and final presentation of our 2023 Evening Speaker Series. I wanted to, of course, thank our valuable industry partners for joining our event. The Nebraska Oncology Society would not be able to meet its mission without your partnership tonight. So here's our agenda for tonight. We're obviously having dinner already and the presentation is about to start. Just a couple of housekeeping items. Please keep your cell phones muted throughout the event. After the presentation, we'll have time for questions. And so feel free to ask our speaker. And the event is being recorded and will be uploaded to our event website at a later date. The event has been approved for 1.0 CME credits. So we'll have our evaluation link ready to go by tomorrow, and I'll send out an email to our attendees so you can complete the evaluation and get your certificate. And for our event tonight, we are hosting a presentation by Dr. Nashin Ahmed. Dr. Ahmed is a board-certified hematologist oncologist at the University of Kansas Cancer Center and assistant professor of hematologic malignancies and cellular therapeutics at the University of Kansas Medical Center. Dr. Ahmed is deeply committed to helping her patients achieve the best possible outcomes through the use of the latest and most effective treatment options available. Her expertise is in the managing of transplant and cellular therapy related toxicities, and her focus is on late effects and survivorship. Her research interests involve quality and process improvements, care delivery with respect to CAR T therapy, and increasing diversity in clinical trials. She is also actively involved in research aimed at improving outcomes for patients and helping to advance the field of cellular therapeutics. She strives to identify and meet the unique challenges of transplant and cell therapy survivors. Welcome, Dr. Ahmed.
Thank you, Carmen, and I wanted to thank our organizers for inviting me to speak about this topic on survivorship, and for your time this evening. So this is going to be a very light talk. This is just general concepts in survivorship after an allo transplant and after CAR T. What does life look like after cure? These are my disclosures. These are the objectives. So we want to see allogeneic transplant. What is the data on survival, causes of mortality in survivors, and how do we improve outcomes? Common post-allogeneic stem cell transplant complications, and what is the link between graft versus host disease and late effects? I will also touch upon CAR T and some late effects, really with a focus on infection and prevention of infection, and then talk about developing a program, like a programmatic approach towards prevention, early intervention, and management of late effects. So I'll start off with some questions, and we'll go over the answers towards the end of the presentation. What is the most common reason for earlier mortality or premature death of allogeneic transplant survivors compared to age-matched general population? Is it myelodysplasia or a second hematological malignancy, solid tumors, infections, cardiovascular events, or car accidents? Question 2. For transplant survivors, we know that they have a shorter life expectancy than age-matched controls. What is the best strategy to improve overall survival in our so-called survivors? First option is have them followed by the transplant team only. Second is coordination of care, close communication with a PCP, oncologist, and the transplant team for early screening and intervention. And third is start aspirin to prevent cardiovascular events. And then question 3 is, what is the most common cause of early non-relapse mortality in CD19 CAR T patients, that's early, like within the first 6 months. Is it cytokine release syndrome, ICANS, infections, cardiovascular events, or second malignancies? So first, let's talk about transplant. There's a growth in the number of transplants that are being done throughout the U.S. And as a result, with better transplant outcomes in general, we're having, what we really want, which is more survivors. And as our survivors are increasing, so now we have to start focusing on specific care for the survivors, which is late effects or survivorship clinic or teams, or because as time goes on, which you can see on the bottom graph, the incidence of relapse really goes down, and really it's survival with health problems that increases and increases over time. This again shows us that the number of transplants per year, per decade are increasing exponentially. Now, there are two types of stem cell transplants or bone marrow transplants. The first is an autologous stem cell transplant. And essentially, what is that? That's a way that we can give patients high-dose chemotherapy. Chemotherapy that will destroy their stem cells, so you want to have stem cells stored from before to rescue them later, so using that as rescue. And then we have allogeneic stem cell transplants. That's a transplant using a donor. This is more involved than an autologous transplant, where it's the patient's stem cells that are being used. So why is it more involved? It's because it not only involves chemotherapy and or radiation to kind of wipe out the bone marrow and the stem cells, but also later on involves getting the stem cells from a donor, replacing the host's whole immune system with those stem cells, dealing with complications or late effects, or I would say trying to prevent late effects such as graft versus host disease. And there's a whole bunch of immunosuppression, other medicines that are used to do that, which can increase the risk of infections. So it's much more involved. Now, the number of both the autologous stem cell transplants as well as allogeneic stem cell transplants are on the rise. And a general trend is that autologous transplants by far are more common than allogeneic transplants. In these are common indications. The most common indication for an autologous stem cell transplant, which is shown in green, is myeloma. And the most common indication for an allogeneic, which is in blue, is acute myeloid leukemia. Another interesting trend over time, over decades, which you can see here, this is CIBMTR data, is that the patients initially, like years ago, that were undergoing transplant, and this is allogeneic transplant specifically, but this also applies to autologous transplant. Most of my talk really from here on will focus on allogeneic transplant. The patients in the past were younger, fitter, less comorbidities, but now, as you see here in 2019, almost a fourth of patients are over the age of 65. And such patients have comorbidities. They may be more frail than the 20-year-old that has to be transplanted. So the characteristics of the patients is changing and evolving. So this is all great. We have better supportive care for transplants. We have gentler conditioning. Conditioning is the chemotherapy and or radiation therapy, the way we use that before we do the stem, like at the time of stem cell transplant. That even patients over the age of 65 can tolerate that. We have improved management of graft versus host disease, which used to be a really big problem, still is a big problem, but we have strategies to prevent it as well as manage it better, and there are newer drugs that are coming out, which we'll talk about that. We will spend a little time on that because I think that's important. But with all of that, now the next focus is going to be long-term management and late effects. So why is survivorship important? So just drilling in the point here is that our survivors, once they get rid of their disease, are still contending with other medical problems. And we know that their lifespan is shorter than healthy control population. They do face premature death. The life expectancy amongst the 5-year survivors of an allogeneic transplant is estimated to be 30% lower than the general population. And it's not because of relapse. Relapse does account for a small proportion of those patients, but there are other medical conditions that they have to contend with. So how do they die? What happens to these patients if they haven't relapsed? The leading cause of mortality for patients who are allogeneic transplant survivors is solid tumors. And after that is infections. And then after that is really cardiovascular and respiratory issues that lead to morbidity and mortality. So not only is there an increased incidence of death or premature death, but also those that are surviving with an increased chronic health burden. This is a study from City of Hope in Minnesota, patients who were 10-year survivors, and this was between 1974 and 1998. So the numbers may be a bit different now. But 66% of these transplant survivors had at least one chronic health condition compared to 39% of their healthy siblings. So almost double their healthy controls. And 79% of the survivors in this study had at least one non-malignant late effect at 5 years after transplant. So why is that? It's mind-boggling. I mean, we've cured the disease, so why are they facing such issues now? And it is very complex. It starts off with, of course, the patient's risk factors, their genetic predisposition, their pre-transplant comorbidities, and then goes on to things that we've done to them. What conditioning regimen has been used? Has there been radiation? And did they develop any complications after the allo transplant? Did they develop GVHD? Were they on medicines for GVHD? What are the side effects of those medicines? So it all links in to lead to ultimately affect all domains of health, not just physical, but also psychosocial, financial, emotional, sexual. And one thing that has been studied is that, yes, patients who have chronic GVHD do tend to have more chronic health burden diseases. In fact, chronic GVHD is almost, I would say, a condition that they're living with and they're being treated for. So it is a chronic health condition in itself. So I said we'll spend a few minutes talking about GVHD because it's so important in our allo patients. So what is GVHD? What is graft versus host disease? So this is where the donor's immune cells, which are the T cells, the B cells, they recognize the recipient's body organs, any organ, if it's the lung or the GI tract or the skin, as being foreign. And so they attack that. So for example, if they attack, I'm just using the word attack, like if they attack the lung, then the patient can develop a pneumonitis. Or if they attack the GI tract, then the patient can have diarrhea, nausea, or if it's skin, then it can be a rash, or it can be sclerotic skin, depending on where they're at with this. So it can essentially affect any organ. If it affects it within the first 100 days, we call it acute graft versus host disease. That's specific. It usually affects a few organs, and then chronic can go on years and years and years, decades later as well. The pathophysiology is inflammation. There's an acute inflammatory phase with GVHD, is basically where there's immune dysregulation, cytokine release, and an acute inflammatory and tissue injury phase. Then there's a phase of chronic inflammation, dysregulated immunity. And then finally, aberrant tissue repair. So the body doesn't heal to where it's normal, but really ends up with fibrosis. And so you see here, for example, this patient, the skin is all sclerotic and dyspigmented, and that is a case, severe chronic GVHD. The main treatment for chronic GVHD is steroids. And that's important for our talk because steroids have their own set of long-term complications. There are also a spectrum of other therapies. for patients that are steroid refractory. So ruxolitinib, Belumos pseudo, which is the newest one, ibrutinib, photopheresis can be done, MMF, rituximab, all of these are there. Each one of these has its side effects for the duration that the patient's on them, but like steroids, for example, can have long-term side effects. So that was a little background, and I think we'll go over some of the major late effects in a case illustration. And I'm just going to use this case to illustrate it. I mean, this patient's going to have a lot of problems, and just to illustrate everything that we have. Not all of our allogeneic transplant patients end up in this situation, so just to let you know. So we have this case, Mr. JJ. He's a 42-year-old gentleman, runs marathon, really fit guy, executive at a bank. And in 2010, so we're going to follow this patient for the next decade, but in 2010, he developed AML, appropriately treated with 7+3 and went into remission. But it was decided, and you are his doctor, you decided that he needs a transplant, and which is what we would still do in today's day and age, depending on the risk factors. So he ends up getting a myeloablative allogeneic transplant. Myeloablative is just the conditioning that's used here in more intense chemotherapy plus radiation regimen. This was cyclophosphamide and total body irradiation. His donor is a matched unrelated donor. And GVHD prophylaxis, which is used with every allogeneic transplant. In his case, the regimen that was used was tacrolimus and methotrexate. This is a standard transplant. As a transplant, you follow him. He develops some acute GVHD, has some diarrhea. It involves his GI tract, and you give steroids, and it responds to that, and he has no further immediate complication. And he was able to taper the tacrolimus at 8-month mark. So you see him a year later in 2012, and he has no stigmata of chronic GVHD. You assess him to see if he appears fine, but then at some point he comes to you and he has progressive shortness of breath. In your clinic, you find him hypoxic and you send him to the ER. He ends up getting intubated, and that's what his CT scan looks like. So you can think of a list of differentials. But in short, this is just to highlight the pulmonary complications. It can be infectious. It can be bacterial, viral, fungal, because he was recently on immunosuppression. It can be non-infectious. So cryptogenic organizing pneumonia, bronchiolitis obliterans syndrome, GVHD, of course. And in his case, because it was small area obstruction and you got a bronch and there was nothing else, we determined that this was bronchiolitis obliterans. He was treated with high-dose steroids, again, broad-spectrum antibiotic. He improved, made a full recovery. So this case right now highlights the pulmonary complications that we went through all of those differentials. The risk factor for those could have been radiation to the chest, bleomycin exposure, high-dose BCMU, which is another chemotherapy conditioning that's used, total body irradiation, of course, his own personal history with smoking, any prior lung disease, and chronic GVHD. Screening, we typically do at regular intervals PFTs to detect any subclinical deterioration in lung function test, chest imaging if indicated. Okay, so this patient now is 3 years post-allo, and he has some chronic GVHD, which you're managing. So chronic GVHD of the eyes and the mouth. His eyes are dry and dry mouth as well. He also has abnormal LFTs, or abnormal liver function tests, which you have determined is chronic graft versus host disease, and some sclerotic skin changes like the one you saw in the previous picture. So let's talk about eye complications, ophthalmic complications. because although it seems minor and it's all limited, but this can really bother patients and it really affects their quality of life. The cumulative incidence of major ocular complications, 13%, but many patients do have like dry eyes and can have cataracts. Chronic GVHD can cause the dry eyes, lacrimal, conjunctival, lids, cornea can affect those areas. And many patients just need local therapy, like with artificial tears, topical steroids, or some procedures, frontal or cautery, other procedures that the ophthalmologist can help with. Premature cataracts also, especially in the patient's AYA population, are those that were transplanted as children. Really lens shielding, if we're using TPI, can help prevent that. For our own patient, the only thing he needed was some natural tears for his dry eyes and biotin mouth rinses for dry mouth. He has required systemic therapy as well for chronic graft-versus-host disease, for his liver function, required several courses of steroids. We went, and you try to taper it, but you can't get him off the steroids completely, and he ends up on long-term prednisone 10 milligram to prevent flares of chronic GVHD. Well, that goes on. He's living his life, and then you see him a couple of years later. I mean, you're continuously seeing him, but a couple of years later, we check in with him, and his ongoing medical issues. He has developed diabetes since 2013, so 2 years, 2 years post-transplant. He did have hypertension, hyperlipidemia already, long-standing pre-transplant that are still being controlled and managed. So why is this important? This is important because our transplant survivors have a higher incidence of cardiovascular events. Their cardiovascular risk is increased with all of these risk factors, such as dyslipidemia, hypertension, diabetes, any pre-existing cardiomyopathy. And really the treatments would be recognizing this and intervening early. So controlling all modifiable risk factors in our allotransplant patients is essential. If you look at this, you see that the patient has their baseline risk factors, then you add in the transplant, direct effects of chemotherapy, some indirect effects with chronic inflammation and GVHD that can lead to increased incidence of metabolic syndrome, increased risk of heart disease in general. And that graph there shows you that patients who are post-allogeneic transplant, their risk of cardiovascular events just keeps increasing with time. That's years since transplant. In autologous transplant recipients, it also increases, but it does plateau after around 2 or 3 years. So what can be done for this? How can we prevent this? What do we look for? First of all, we have to recognize that it's a major driver of premature mortality in our survivors. The etiology, the chronic GVHD, steroid use, endocrinopathy, age, and all the other risk factors we talked about. And really addressing promptly all modifiable risk factors, hyperlipidemia, diabetes, hypertension, smoking cessation counseling, just going back to the basics will really help the patient. Okay, so now our patient, we're managing all of that. And 7 years post-allo, you learn that he recently lost his job and he got divorced. And then you dig a little further and you find that there's just some subtle things that he doesn't feel right. Some decreased libido that's been going on since the transplant that he hasn't really talked about very much. Fatigue, even though he's 7 years out, he doesn't feel the same, and infertility. So let's talk about fatigue first. So fatigue is one of the most common survivorship concerns, and one of the things that your patient will bring up to you most commonly. And this is one of those vague symptoms that we don't always have a solution to. We have suggestions because it could be so multifactorial. Interventions can include recognizing any biological causes, any endocrinopathies, anything like that, recommending exercise programs, nutrition, hydration, sleep, stress reduction, and many times we have to even get cognitive behavioral-based strategies. Before we talk about other things, really, you have to investigate any endocrine effects. So, low testosterone, premature menopause in females, male hypogonadism, low sex drive. These are questions we don't always ask our patients every visit, but we should be asking, say, about their sex drive, which, we do in our survivorship clinic. I guess in our normal clinic, we don't have necessarily the time or the resources to ask about every aspect of their life. Investigating routinely for thyroid disorders, understanding that they are at a high risk of diabetes, especially like the patient scenario that we have, looking for adrenal insufficiencies. The risks, again, specific risks would be high-dose chemotherapy regimens, exposure to busulfan, BCNU, radiation to pelvis, total body radiation. And then screening would be with yearly TSH, especially if we know that the patient has had radiation to the neck, chest area, checking testosterone levels, which we do at least once a year, FSH estradiol levels as indicated. So the fatigue and all the, if the patient has an endocrinopathy, if they're on multiple medications, that does affect their quality of life. So does chronic GVHD. If you have a patient living with chronic GVHD, their quality of life, their perceived quality of life is lower than someone that does not. They have more depression, more anxiety. The bars here, there's assesses their physical function, the one to the left, and then the mental competence score. So do they feel that they're physically functioning well? Do they have more pain? What is their general health perception of their general health? What is their perception of their social functioning? Mental health. So it's really lower in all domains. And this is also tied in with late complications and long-term complications. So the burden of late mortality can really also tie into their general well-being. How do they feel? So if they're dealing with more health issues, there's worsening physical function, there may be more severe limitation of usual activities, lower likelihood of returning to work, their social life can be disruptive, their work life can be disruptive. So late complications have a major impact on patients and their life in general. We don't talk about this very much, but this is reality. There is a financial burden in our survivors. 26% of them have a decreased household income by more than 50%. 25% withdraw money from retirement accounts. There's many, 9% that have to end up with mortgage, and 3% bankruptcy. And of course, with all of that going on, it's not surprising that they have an increased risk of suicide, males and females, both of them, compared to the general population. Well, going back to our case, so our patient is anxious about cancer, recurrence of the cancer, new cancer. And he asks you a question. He asks you, is he at increased risk of which of the following? I mean, would it be skin cancers you're worried about, oral cancers, a second blood cancer such as myelodysplasia? I mean, technically all of them, but really skin cancers are the big one. The solid malignancy, second solid malignancy is the #1 leading cause of death in our survivors. This risk continues with time and does not plateau. And an individualized screening program or individualized screening plan is important for such patients based on their risk factors and whatever they've been exposed to for conditioning. So here you see that for new secondary solid cancer, their risk factors such as previous exposures, did they have HPV infection? Did they have any genetic predisposition? Lifestyle factors. And then, of course, you throw in the chemotherapy, radiation, maybe the total body radiation, and then if they get graft versus host disease, that can all lead up and add up to their risk of developing cancers. These are some examples like melanomas, other squamous cell cancers that we see. Oral cancers are common too. We have our patients see a dermatologist at least once a year, maybe more frequently if needed. And then oral cancers, we have them see like a dentist at least twice a year. Nothing out of the norm, but these are important for these patients. HPV vaccination has really helped prevent some of these cancers. If you have a patient with GVHD, their risk of HPV reactivation is higher, and it can continue to go higher over the years. And that's because many of them are on immunosuppression. They can have more viral reactivation. An HPV can drive, pre-cancerous condition and ultimately cancers such as cervical cancers. So that's part of our immunization strategy. We have a whole immunization program for our allotransplant patients, and this would fall into that. But looking at other general cancer screening, I mean, that's the one preventative thing, but general cancer screening recommendations, breast cancer, depending on the risk factors, but otherwise it's really mostly standard preventative. It's just that adhering to it, really, reinforcing that is really important to get cancer treatment based on the risk, based on the age. And that's a reference. And this shows how HPV vaccinations is one of the main preventative strategies to prevent HPV-driven cancers. So that was all for the allogeneic transplant setting. So just a little bit about CAR T therapy for lymphoma and myeloma. And many of you are familiar with CAR T, but it is one of the genetically modified treatments that we have since 2017 for lymphomas and more recently for myelomas. In which the patient's own cells, their T cells, are taken, genetically modified, and then given back to them with some chemotherapy. And that can be curative for lymphomas and not yet necessarily curative in myelomas, but almost getting there. There are some complications that we, like at KU, we have a survivorship program in which we also see CAR T survivors. How is this different from a regular lymphoma or myeloma survivor? I don't know the answer to that. I mean, this is a type of treatment for them. It's just that it's more associated with increased risk of infections, and that's why we follow them more closely. And then, of course, there's also some risk, theoretical risk, that because there's a viral introduction of that genetic material, that there's a risk of cancer down the road. So we're monitoring for that as well. But let's just focus on infectious part of complications for CAR T. So we have here a 53-year-old female, was diagnosed with DLBCL in 2015, got R-CHOP, went into a CR, did really well, several years. And then in 2023 is when she had an urgent visit, new lump in the groin, night sweats, and now you confirm that she has lymphoma relapse. So you plan for CAR T. In this case, it was Axicell. She got the CAR T. Usually the transplant cell therapy team follows for around 30 days. We confirm that she has CR, and now she's back with you. And so, what are you going to watch for? The late effects of CAR T, that is, when I say late effects, I'm talking about like beyond 28 days. So it's not that late, but it's, extending beyond 28 days. In the first 28 days is, of course, the risk of cytokine release and ICANS. Those are some toxicities that are specific to CAR T and bispecifics, but more CAR T. There's a host of infections, bacterial, viral, fungal, because they can be neutropenic for a period of time and then they recover their counts. Most of them do. But really after the 28-day period, we're still watching for infections, still bacterial, viral, and fungal infections, PJP infection. These patients have to stay on prophylaxis with acyclovir, with PJP prophylaxis. We have to watch for hypogammaglobulinemia. There's B-cell aplasia. So being very alert or being very aware that if they call in with a cold or if they call in with a cough, it's not your regular patient that's just calling in. These patients can have pneumonia. They can decompensate pretty quickly. The general recommendation is to watch for hypogammaglobulinemia, check IgG levels monthly. If they're low, replace them. Vaccinations. We have, following Joshua Hill's recommendation, we have adapted our autologous transplant vaccination schedule for our CAR-T patients. And use prophylaxis like I just described, acyclovir and PJP prophylaxis. So that is, in a nutshell, those are just the tip of the iceberg for what our survivors face. There's a lot more. I could spend the whole day talking about it, but these are just to highlight a few basic points or basic things that you'd see in the life of an allogeneic transplant recipient, and a little bit about CAR-T. The last piece of this is how can we help these patients, and what can make their life better, what can increase their survival. So we have to look at the patient. Of course, the patient's the center of this. The patient has a relationship with the transplant team, their allogeneic transplant doctor team. They have a relationship with their own hematologist that may be outside the transplant team, and they have a relationship with their primary care doctor. So each stakeholder is doing their own thing, but there's no real good communication maybe between all of these different, specialties that are taking care of the patient. And that's where survivorship, a dedicated survivorship program may come into play, may have a benefit for the patient in terms of making that bond between all the specialties involved in the care of the patient. So I'm the director of the survivorship, of the transplant survivorship program at KU. And what we have is it's run by 2 nurse practitioners. We have a relationship with our, gynecologist that takes care of GVHD, ophthalmologist, our dental folks that are just specialized in GVHD, our pulmonologist. So we have specialties at least within our area that we know where to send these patients if they're having problems. We make an effort to put in a plan in place for the patients, what individualized screening and all of that, which is communicated not only just to the patient, but also to the transplant team, to the hematologist, as well as a PCP. And then we've added in the last year also who does what, because it's assumed that, okay, the PCP is going to take care of the cholesterol, but the transplant team is actually doing it. So it's really, like who does what is also outlined. Because the patient does not know. The patient's under care of so many different providers, they do not know. So this helps to give them a better idea and more empowerment. So it functions in, in different ways. I mean, it helps to prevent, the focus is prevention. The fact that the survivorship team is nested in our BMTs, because those nurse practitioners, they know transplant, they understand the complications of transplant, they can help be the liaison, the bridge between all the different teams. Surveillance, intervention, early intervention is key for all of this. And then, of course, coordination between specialist primary care. And then ultimately is education and empowerment, and letting the patient know, letting the patient understand who's driving what. So that was the end of the content. Getting back to the questions. So question 1, what is the most common reason for earlier mortality of our transplant survivors compared to age-matched general population? And I hope that you all got it, that solid tumors is a big deal for these patients. And then question 2, transplant survivors have a shorter life expectancy than age-matched controls. What is the best strategy to improve the survival in our survivors? It's really coordination, communication, and early screening, intervention, and everything we talked about. And then for our CAR-T patients, what's the most common cause of early non-relapse mortality? What is it that kills these patients? It is not CRS or ICANS, which everyone's worried about. It's actually infections. So that's critical to recognize that and to take if they have a symptom, to take that seriously. All right, thank you very much for your time and attention this evening. Thanks a lot. Any questions?
Okay. Do we have any questions for Dr.
You could brand the different from the different patterns that they was really like everything from patterns
Difference in the infections? Not really. So it depends. So if you get a lymphoma CAR Ts, I would say that most of them are similar. With the myeloma CAR Ts, there's some other things to look out for. With still there's myeloma CAR Ts, I didn't get that. I just haven't seen stuff. So yes, it was CRS and ICANS, which is there. But I read with so there's also some reports, it's not very common, that's still there, of movement disorders and Parkinsonism. So that's something to look out for. Because most of the patients who develop that will be when they're back with their hematologist. So recognizing that there's no formal normal assessments that are done beyond the 28 days that in the beginning of the world, especially when all that, like first 28 days. After that, it's just waiting for them to report these things. So.
Good morning, everyone. You yeah.
You're talking about allogeneic transplant.
I'm not even on the general volunteer survivorship effort and integrating all this into some type of transferable package so that one center can become excellent and transfer it readily to the center.
That's a really good question.
I'm sure you know it.
So it's a very complicated question as much as it's a simple question, right? So the biggest thing is when we think about involving other centers, right? Whether it's CAR T, auto transplants, or allo transplant, allo being the most complicated. I mean, that's way more complicated. It is a resource. So yes, we can always, share that protocols everything. Like, okay, if this happens, this is what we do. So it's all protocols different out. Then all of the tasks are it's like there's certain steps to yes, we could share it. And what happens is that it ends up being resources like we have not really in particular, but we like Pleasant Center have that 24/7 call abilities that they can call and get in to a hospital bed within 30 minutes if needed, without bypassing the ER, because especially for allogeneic transplantation, we cannot let them go to the ER unless they're really having a heart attack. We get them directly admitted. We have a pathway like that. Similar with our T patients, they always have a 28-day period. They don't have to go to the ER because they can die of infection that they acquire from the ER. So having that resource, that infrastructure, I think more than the eye, is the main thing. I've been also looking at how we work with our own community sites near us, maybe some patients, is RT or something like that. But I think it depends on the boils down to that structure. So we have tools, it's the resources and like we have the setup. We're getting sensitive over there in OSU with the participation or out transplantation. At a center of excellence, there's a whole team of people that know exactly who they think about GVHD, right? If you have a transplantation or who is just think about pneumonia. It's really a niche, at least for our transplant. Somewhat with RT, but as long as there's more awareness, so at least we can have unusual infections and all that, and they have a pathway to get to like things like bypassing the ER. Those will be important.
what do you think about the role of cell phones and the patient advocates for that integrated with your system and using that as the help? Then with the outside position and so forth. Is there any evidence being done? Then, I mean, I know iPhone has still had a thing, but is there a way that it's an iPhone?
Yeah, I think we'll see that coming. So, like, for example, what you're asking, what would be ideal? Like, could there be an app in a system where these things are documents that you wear on devices, right? It's all documented either directly integrates into the EMR system of whatever facility you choose, whether that's facility you're referring a doctor, whether that's surgery center, like whatever facility you choose. We'd love to see that happen. I know there's some places that are trying this out. It's still in very early, like we're not interested in that. We haven't started doing that. We're looking into research that would support that. I think that would be really important. That would be very helpful also to get that. Like party, and I know that like Nebraska, sorry, cancer specialists. That just started their party program, and so there are places that there can be done. There's good resources, and yes, technology will help us. It's just not there yet.
How does your entire survivorship system work when it comes to patients out? I mean, Kansas has the same problem with rural patients that probably comes with us. So how does the coordination work? Trying to work those logistics when specialists such as your ophthalmologists, even dentists are in shortage. A lot of these patients are in shortage areas. How does your team work with that?
Yeah, so we work very closely with their oncologists locally, because the oncologists locally will know the resources locally and might be able to then, they can really collaborate with us. So if a patient comes even if they see, say, our ophthalmologist like once a year, but that ophthalmologist can tell the ophthalmologist locally what to do, that helps a lot. For some of our stable survivorship patients, the ones that don't have a lot of issues going on, we just need telehealth at least to save them a visit, save them time. The ones that do have like everything that you saw in this patient, and there are a few patients like that. Not everyone's like that. Okay, but they do end up having come a little more often. Some of them hate it. They don't like coming. So we try to work as much as possible with their like local team to make things happen closer to home. And I was talking to a bunch of people, like as biospecifics move out. I think this will be another thing, infections and how they get monitored in the community. How does technology help us with that? Because there's some of these risks that we saw with CAR T, not at that magnitude, but there's still pre-existing biospecifics. So a lot more exciting things coming out in the near future. And then we have to know how to take care of these survivors. So.
So thank you again, Dr. Ahmed, for sharing your time and expertise with us this morning, or sorry, this afternoon. I wanted to share additional information with all of our members and our guests about future events coming up in 2024, and we hope that you're able to participate. We'll have our usual Winter Breast Cancer Symposium on Saturday, February 10th. Right here in the other section of the hotel. And then our mid-year review will be over at the Embassy Suites in La Vista. So different venue. And then once we have all the dates and speakers set up, we'll also be sending the 2024 evening speaker date events as well. And with that, thank you, everyone. We've reached the end of our presentation and the end of our event and the end of our 2023 evening speaker series. Thank you again for attending and participating, and for our speaker again for sharing her expertise with us. And please enjoy the rest of your evening. Thank you.